Patients here.
Oh boy, got some blood going.
Yeah, there's blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in application for
your left hand.
45 minutes of CPR. We can stop CPR with 600, 600, 600.
Welcome back to The Deep Dive, the show that takes that overwhelming stack of pediatric source material, filters out all the noise, and really just delivers the critical, high-yield knowledge you need to ace your exams and walk confidently into clinical practice.
Today, we are focusing our energy on, well, arguably the most fascinating group developmentally, the preschooler.
Ages 3 to 6, right?
Exactly. It's this pivotal time when the highly dependent toddler morphs into an independent, imaginative little person. If you're preparing for PEDS exams, the preschooler is mandatory knowledge.
Why is that? What makes them so critical?
Because they are the nexus where physical readiness meets the chaos of pre-operational thought.
That's a great way to put it. This is definitely the age group where I see nursing students trip up because they are a bridge.
They are.
They're leaving that intense physical growth rate of infancy and entering this world defined by imagination and rules and questions. So many questions.
The why stage.
Oh, absolutely. So our mission today is crystal clear. Distill the essential developmental theories, link them directly to required nursing care and safety, and absolutely master the school readiness components, especially that daunting immunization schedule.
Yeah, and we've synthesized a lot of sources for this one, from the rigid clinical guidelines on growth curves and CDC vaccination schedules to the more nuanced psychological frameworks of Erickson and Piaget.
So we're connecting the dots.
We have to. We need to connect the development of their conscience, the explosion of their motor skills, and their peculiar cognitive processes directly to the interventions you, as a nurse, must perform.
Okay, let's unpack this. I think we should start with the physical transformation. Compared to an infant or a toddler, the preschooler's physical growth seems to slow way down, but that's actually a key sign of maturation, right?
It is.
So what are the foundation points we need to know about their physical body?
Okay, so the key word here is consistency. The growth is slow and it's steady, which marks a move toward what will become future adult norms. Weight gain averages about 4 to 5 pounds per year, and their height increases by about 2.5 to 3 inches per year.
Those numbers seem so small compared to the first year of life.
They are. And that's why clinically we're not so focused on the number itself. We're watching for one thing: consistent movement along their established growth curve.
So if a child drops from, say, the 75th percentile down to the 25th for height or weight within a year, even if the numbers are still technically in the normal range, that's a massive clinical flag.
Precisely. It is the deviation from their personal trajectory that alerts us.
Got it.
And, visually, this is the phase where they shed that toddler chubbiness.
They start to thin out.
They do. They actively lose baby fat, that padding of infancy, and start gaining lean muscle mass. This gives them that stronger, slimmer, more athletic look. It's really preparing them for the gross motor explosion we're going to talk about later.
And that change in body composition must affect their balance, too.
It fundamentally shifts their center of gravity. It's why they become far less clumsy than their toddler counterparts.
That makes perfect sense. Increased muscle, better balance, fewer of those classic toddler tumbles.
Exactly.
Okay, so let's talk about the maturation happening kind of beneath the surface, specifically in their physiology and their vitals. How are their vital signs changing to reflect this move toward adult function?
Their cardiovascular system is maturing significantly. We see the heart rate continue its normal descent.
It was slowing down.
It is, which reflects the increased efficiency of the heart muscle and stroke volume. And at the same time, their blood pressure gradually increases slightly, which is a completely normal developmental trend as they head toward school-age ranges.
I remember a clinical note about this age group and heart sounds, something specific nurses need to be aware of.
Yes, absolutely. It's crucial for documentation. An innocent heart murmur, a functional benign murmur, may be occasionally heard in this age group.
Why is that?
It's due to the rapid structural and flow changes occurring in the chest cavity as they grow and mature. A nurse has to recognize it, document it, but generally understand that in an otherwise asymptomatic child, it's often a benign finding.
But it always warrants a follow-up, just to be
Oh,
sure.
always.
Yeah.
You always want to confirm its innocent nature, but it's a great example of that clinical nuance that exams just love to test.
Okay, moving on to the neurological system. There is a massive shift here that dictates one of the most visible milestones of the whole preschool period.
This is the neurological key to the entire age group. Complete myelination of the spinal cord is achieved by approximately age 3.
And myelination it's like the insulation on a wire, right?
Perfect analogy. It's the insulation that allows nerve impulses to travel rapidly and efficiently. Before this is complete, control is highly reflexive. But once that myelination is done, the nerves controlling the bladder and bowel sphincter muscles are fully mature.
Which allows for
Voluntary control, voluntary inhibition and release.
So this is why a 2-year-old might struggle with potty training. It's not behavioral, it's anatomical. They just haven't achieved full physical readiness yet.
Exactly. So if a healthy 3-year-old is struggling, we've ruled out that physiological barrier of myelination, and we can confidently address the issue as developmental or emotional or behavioral.
But if a child enters the preschool years and still shows no progress in sphincter control, that's a red flag.
That demands a more comprehensive neurological assessment. This myelination fact is its prime test material.
Okay, let's pivot to infection risk. Why, despite their systems growing, do they remain so susceptible to common childhood illnesses, especially things like ear infections and UTIs?
It really comes down to immature structural anatomy in a couple of key areas. First, the respiratory system is improving, the alveoli increase in number, airways get bigger, so they're less prone to those lower respiratory illnesses of infancy. But in the head, eyes, ears, nose, and throat system, the HETA system, their eustachian tubes remain short and, critically, very straight, more horizontal.
And that horizontal orientation is like a straight pipeline for germs.
It's a direct conduit. Bacteria and secretions from the back of the nose and throat can travel horizontally with almost no difficulty right up into the middle ear.
Which predisposes them to recurrent otitis media.
Exactly. So as a nurse, you're always watching for those subtle signs like pulling at the ears or a fever, knowing this structural vulnerability is there.
And the genitourinary system, the GU system, has a similar vulnerability, doesn't it?
Yes, the urethra remains short in all young children, which predisposes them to UTIs, especially in girls.
Because it's a shorter path for bacteria to travel.
Right. It allows bacteria, often E. coli, to ascend very quickly into the bladder. Nursing care here involves vigilance for symptoms like pain with urination, frequency, or urgency, and of course providing excellent hygiene education to parents and to the child.
And we can't forget about teeth. Dentition is a big focus in the exam room.
It is. By the time they enter this preschool period, all 20 of their deciduous or primary teeth should be fully erupted.
So the nursing focus shifts.
It shifts heavily to preventive dental care. Parents need guidance on fluoride, ensuring regular dental visits, and active supervision of brushing to prevent those early childhood cavities, which can actually affect the placement of the permanent teeth that are developing right underneath.
Okay, so this section really defines the physical landscape. We have steady growth, mature neurology that leads to potty training, and 2 key structural weak spots, the ears and the GU system, to keep an eye on.
That's a perfect summary. So for what nurses watch for, you're checking for consistent progression along their established growth curves, not just looking at the absolute number.
And you're observing for symptoms that point to those vulnerabilities.
Right. Signs of an ear infection or a UTI because of those short eustachian tubes and urethra.
Now, what exam writers love to test?
The specific physiological reason for achieving voluntary potty training. Complete spinal cord myelination by age 3. That connection is clinically crucial, and it is highly, highly testable.
And one easy way to remember this age group.
They're losing their toddler chubbiness and starting to look like little people gaining muscle, losing fat, and getting ready for that explosion into coordinated activity.
This increased physical ability wouldn't be possible without a massive leap in how their brain controls their body, and I think more importantly, how their brain perceives the world. So let's talk about the psychological key. Erickson stage for ages 3 to 6.
Okay, so we enter the stage of initiative versus guilt. And this is perhaps the most defining psychosocial stage for the preschooler.
What does initiative really mean here?
It means the child is now an energetic learner, actively planning and attempting activities. They love starting new projects, making up games, and they have this intense desire to please their parents. They're practicing their independence through action.
This is where we see that explosion of make-believe play, right? Where they take the initiative in creating entire worlds and stories. They're testing out their boundaries and their competence.
Exactly. And they are developing a conscience. They realize they can start things, but because their abilities still often exceed their judgment, they sometimes fail or break rules or misbehave.
And that's where the guilt part comes in.
That's the opposite of initiative. Guilt occurs when their attempts at initiative are constantly thwarted or criticized or overly punished. They begin to develop feelings of remorse and start to believe they are inherently bad for their actions or even for their desires.
This emerging conscience ties directly into Kohlberg's theory of moral development. They're operating primarily in that pre-conventional level, right? The punishment-obedience orientation.
That is the critical link. For the preschooler, an action is good or bad based purely on the immediate consequence.
So if I hit my brother, I get sent to timeout, so hitting is bad.
Precisely. If I share my toy, I get praised, so sharing is good. They don't yet grasp complex intent or abstract moral principles.
Which means discipline has to be immediate, clear, and consistent.
Yes, to link the action directly to the consequence. That's how you foster initiative while minimizing that sort of paralyzing guilt.
That explains so much about their sensitivity. Okay, let's move to their cognitive framework. Piaget's pre-operational stage, which spans ages 2 to 7 and explains why they view the world and illness so strangely.
The pre-operational stage is a world governed by appearances, not by logic. It's split into the preconceptual, which is ages 2 to 4, and the intuitive, from 4 to 7.
And they lack the concept of conservation.
Right. They believe a tall, skinny glass holds more water than a short, wide one, even if they just watched you pour the water from one to the other. Their thoughts are influenced so heavily by what they see.
And this flawed logic leads directly to that trifecta of cognitive concepts that nursing exams test so heavily: magical thinking, transduction, and animism. Let's start with magical thinking and its huge clinical implications.
Magical thinking is the belief that their thoughts are all-powerful. It often leads to this sense of omniscience. In a clinical setting, this manifests as self-blame.
What's a classic example of that?
The child was angry at their mother and secretly wished she would go away. Then the mother gets sick and is hospitalized. The preschooler becomes convinced that their wish caused the illness.
Wow. So if a nurse admits a preschooler whose sibling has just been diagnosed with a serious illness, the nurse's primary proactive communication has to be, nothing you did or thought or said made your brother sick.
You have to explicitly counter that internal guilt.
You have to say it out loud.
Absolutely. The guilt can be overwhelming and it can impede their healing or their cooperation.
Okay, next up is transduction.
Transduction is taking one specific instance and extrapolating it inaccurately to a general rule. They don't grasp cause and effect logically. They just generalize based on chronological appearance.
Give us a clear, high-yield example of transduction in the hospital.
Okay. If a nurse, let's call her Nurse A, comes in, takes the child's vitals, and immediately after that, the child gets a painful shot from the doctor. The child uses transduction to conclude that Nurse A caused the pain.
Or even worse, every time a nurse touches me, something bad is going to happen.
Exactly. They generalize the negative experience of the shot to the non-painful experience of getting your blood pressure taken, or even to the entire profession. It is a major barrier to building rapport.
That's fascinating. It really emphasizes why procedural preparation needs to be separated from the actual performance of the procedure.
It does.
And finally, animism.
Animism is attributing human or lifelike qualities to inanimate objects. This is why their teddy bear is their best friend, or why they might get mad at the table they bumped into.
So clinically, this means they might believe the IV pole is breathing.
Or that the blood pressure cuff is trying to squeeze them to death. We see this all the time with equipment fears.
So you should never say something like, the machine is broken.
Never. Because the child may believe the machine is just sad or angry. This all confirms why simple, concrete language is so essential. We use play like puppet play, but we have to be so careful about the materials we use. Well, if you use a doll to demonstrate a shot, the child might believe the doll is now permanently hurt. So it demands total clarity. We use the concept of doing a procedure on the doll, not hurting the doll. The use of play is vital for mastery, giving the child control by letting them place a bandage on the doll or listen to a teddy bear's heart. This counters their intense fear of bodily harm and loss of control, which is just compounded by their pre-operational thought.
Okay. So what nurses watch for?
You're watching for signs of self-blame or overwhelming guilt related to a family illness or hospitalization. Nurses must use simple, direct, concrete language and actively dispel magical thinking. You have to say, this sickness is not a punishment for being bad.
And what do exam writers love to test?
They love matching Erickson's stage, initiative versus guilt, with its core outcome, the development of conscience and moral understanding, which is Kohlberg's punishment obedience. Also, scenarios where you have to identify and apply the correct technique to counteract animism or transduction in a clinical setting.
Perfect. And one easy way to remember this age group.
They're the group pre-operational, preconceptual, and preschool. Their entire world is defined by what they see, not by what they logically know.
So because of that physical maturation we talked about, the myelination, the muscle game, losing that top heaviness, the preschooler undergoes a truly spectacular explosion of coordinated motor skills.
It really is an explosion. If a nursing student can just track the progression from age 3 to 5, they'll grasp the entire physical development of this period.
Okay, let's nail the hallmarks then. Age 3 is the age of independence, and it's powered by the tricycle.
The 3-year-old is highly independent. For gross motor skills, they can climb well, run easily, and critically, they can pedal a tricycle.
Which requires a lot of coordinated movement and balance.
It does. And the biggest fine motor achievement is that they master walking up and down stairs using alternate feet, so they're transitioning away from that toddler 2 feet per step shuffle.
And their fine motor skills.
Also crucial, they can undress themselves, hold a pencil in the correct writing position, build a tower of 9 or 10 cubes, and the one that always shows up on tests, they can copy a circle.
The circle, that is the classic 3-year fine motor check. Okay, what massive leap happens at age 4?
The 4-year-old refines their gross movements and gains more control. They transition from just climbing to true agility.
So for gross motor,
they can throw a ball overhand, which is a complex skill involving trunk rotation. They can kick a ball forward and hop on one foot. They can also stand on one foot for up to 5 seconds.
And fine motor gets more precise.
A lot more precise. They can now use scissors successfully, copy capital letters, and draw circles and squares. And they can draw a person, but typically only with 2 to 4 body parts, like a head and maybe 2 limbs sticking out.
And the 5-year-old is essentially school ready. They have skills almost comparable to an adult in terms of basic mobility.
That's the goal. The 5-year-old demonstrates complete mastery and coordination. For gross motor, the hallmarks include standing on one foot for 10 seconds or longer, swinging and climbing well, and the ultimate coordination marker, skipping.
Skipping is a big one.
It is. They can also somersault, and they often start structured activities like basic skating or swimming. For fine motor skills, they're impressive. They can print some letters, dress and undress completely without any help, and they can use cutlery, including a supervised knife.
And the definitive fine motor milestone.
They can copy a triangle and draw a person with a body and at least 6 distinct parts.
That progression tricycle at 3, scissors at 4, and then skipping in the triangle at 5, that's a perfect memory hook for an exam.
It is.
But physical skills aren't the only explosion. Their language becomes functionally adult-like.
Yes. The sheer volume of language increases, and the quality improves dramatically. By age 4, their vocabulary hits around 1,500 words. They speak in complete sentences with adult-like grammar.
And there's a key nursing check for them.
Yes, their ability to follow a 3-part command. If you can tell a 4-year-old, pick up the block, put it on the table, and give me the ball, and they do it, their auditory processing is on track.
And by 5, they're basically fluent in asking all those critical thinking questions.
Their vocabulary grows to 2,100 words. They can explain how to use something. They can talk about past and future events, which is a huge cognitive leap, and they're constantly using why and when.
Their language reflects their cognitive effort to understand cause and effect, even if their pre-operational mind still struggles with the logic.
That's a great way to put it.
So for a nurse, tracking these milestones is just the first step. The really crucial part is recognizing the red flags and initiating that referral process. What are the key signs of developmental delay we have to watch for?
Early recognition changes outcomes. We have to be particularly vigilant for a 4-year-old who has difficulties with gross motor skills, like they can't jump in place or ride a tricycle, or fine motor signs, like not grasping a crayon with their thumb and fingers.
And for communication?
We'd be concerned if they can't use me and you appropriately, or, and this is critical, if they do not engage in fantasy play.
Why is that lack of fantasy play such a major red flag for a 4-year-old?
Because fantasy play, role-playing, is how they process their world, is how they practice social skills and develop that sense of initiative we talked about. If that's absent, it signals a potential broader delay in their cognitive or social development.
And for the 5-year-old?
Red flags would include little interest in playing with other children. That's a social marker. Or continued language deficits, like they can't use plurals or past tense.
And what about their attention span? That's directly related to classroom readiness.
Absolutely essential. If a 5-year-old is easily distracted and cannot concentrate on a single activity for 5 minutes, that is a massive concern. 5 minutes is the bare minimum attention span required for structured learning tasks. If they can't maintain that focus, it's a likely obstacle to classroom success and warrants immediate follow-up.
Okay, so let's summarize this section. What do nurses watch for?
You're watching if a 4-year-old struggles to follow a simple 3-part command, or if a 5-year-old cannot sustain concentration on a single activity for at least 5 minutes. These are highly specific, quantifiable markers that tell you a referral is needed.
And what do exam writers love to test?
Identifying the definitive physical milestones, the 3-year skill, which is pedaling a tricycle and copying a circle, and the 5-year skill, which is skipping and drawing a person with 6 parts.
And an easy way to remember this age group.
They are the age of gross skills getting finer. They conquer the coordinated tricycle at age 3 and the complex triangle at age 5.
The physical and cognitive growth really fuels their work, and their work at this age is, well, it's play. How does their play evolve socially from the toddler who is content with just parallel play?
The defining shift is moving from parallel play, which is playing merely next to another child, to associative play.
And that happens around age 3 or 4.
Typically, yes. In associative play, children engage in similar or identical activities. They exchange materials, they talk to each other, and they might even participate in a group.
But there's a key distinction here.
There is. There is usually no formal organization, no mutual goal, and no specific role assignment. They're playing with each other, but not necessarily for a shared outcome. True cooperative, competitive, or highly organized play, that awaits the school-age period.
Okay, so if they're building separate towers in the same sandbox and borrowing each other's shovel, that's associative play. But if they're planning a detailed script for a puppet show, that's moving towards cooperative play.
Precisely. And the activities we suggest must support this development. We encourage things that promote all domains. Playing ball, doing puzzles, sandboxes, dress up, and especially role-playing or fantasy play.
Role-playing seems incredibly vital.
It is. It's their safe laboratory to practice conservation skills, to sample behaviors, and to work out those initiative versus guilt conflicts. They can be the doctor or the parent or the teacher.
Speaking of role-playing, we should probably address the imaginary friend, which I know often causes a lot of anxiety for parents.
The imaginary friend is a completely normal and often a very healthy developmental tool. It's a creative way for the preschooler to practice conversation skills, to test out social rules, and to work through complex emotions.
It's a low-stakes relationship where they're always in control.
Exactly. They never feel judged. A nurse should respect this friend as a valid part of the child's world. You wouldn't dismiss the child if they talk about their friend's preferences or worries.
Socially and emotionally, their ability to navigate real relationships takes a huge step forward, too. What are they mastering here?
They are learning the foundational skills of making and keeping a friend, which involves cooperation, sharing objects and feelings, displaying affection, and learning basic generosity. They're becoming more empathetic, but their empathy is still largely based on observed consequences.
Like, if I cry when I fall, my friend cries when they fall. We talked about their sensitivity earlier because of magical thinking. Let's double down on the fears they exhibit, especially in the hospital environment.
The major clinical fear for the hospitalized preschooler is fear of bodily harm or mutilation. Their pre-operational mind struggles intensely with the concept of body integrity.
So they believe that even a small cut or a puncture is permanent.
Yes, and that their internal stuff might leak out.
This fear is why procedures like getting a shot or drawing blood or placing an IV are so absolutely terrifying for them. The needle represents a permanent break in their physical integrity.
It does. And this fear dictates key nursing interventions. Always provide a bandage, no matter how small the puncture, because the bandage visually keeps the insides in.
And you have to use non-threatening language.
You must. Avoid words like cut, stab, fix, or put to sleep. Instead, use make a small opening, clean, or help the sore get better. We have to minimize their imagination filling in those terrifying gaps.
Let's transition to managing behavior. What are the principles of discipline that support their development of initiative without causing that crippling guilt?
Discipline has to exist within a loving, nurturing relationship, and it needs to be defined by clear, consistent, and immediate limits. The goals are to teach the difference between right and wrong, encourage self-control, and foster empathy.
And physical punishment is out.
Strongly discouraged by the American Academy of Pediatrics. Striking or spanking just models aggression, and it fails to teach self-regulation.
So the highest yield discipline technique for this age is timeout. What's the standard nursing guidance on how long a timeout should be?
The timeout rule is simple and it's highly effective. 1 minute per year of age. A 4-year-old gets 4 minutes, a 5-year-old gets 5.
And the space matters too.
The timeout area has to be boring, non-stimulating, and safe. Not the room full of toys, but a designated chair or a quiet corner. And the timeout must begin after the child is quieted down, not while they're still thrashing, to ensure they learn self-regulation.
And what about the common issue of lying? Why is it such a staple of this age?
Lying is extremely common, and it's a symptom of 2 underlying issues: fear of punishment and those blurred lines between fantasy and reality, which is their magical thinking. They desperately want to please, and if they think admitting they broke the vase will lead to severe punishment, they'll choose the path that avoids that consequence.
So the nursing guidance to parents has to address both the action and the root cause.
Exactly. Parents should gently acknowledge the child's fear, then guide them back to reality. Avoid labeling the child as a liar. Instead, you address the behavior. The vase is broken, and I know you are scared of being in trouble, but the truth is important. This reinforces truthfulness without damaging their emerging self-worth and initiative.
Okay, let's wrap this section. What should nurses watch for?
If a 5-year-old exhibits a lack of interest in playing with other children, or if a child of any preschool age fails to engage in fantasy play, these signal potential deficits in their social and cognitive development.
And what do exam writers love to test?
Identifying associative play as the primary type of play, it's not cooperative yet, and the critical understanding that the preschooler's greatest fear is bodily harm or mutilation.
And the easy way to remember this age group.
They're shifting from playing next to others, which is parallel play, to playing with others, which is associative. And they use make-believe as their primary tool for working through their conscience.
So if we synthesize what we've talked about, their high mobility and strong physical capability combined with that pre-operational illogical judgment, we get an age group at extremely high risk for accidental injury.
Absolutely. Injuries remain the leading cause of death in this age group, so our teaching has to be laser-focused on prevention.
We have to remember they just lack the ability to truly assess danger.
They're risk takers because they have initiative, but they don't have the abstract thought to predict the consequences.
So the top risk, statistically, is still motor vehicle injuries. Let's cover the car seat rules, which are mandatory for nurses to teach consistently.
Okay. Preschoolers must be secured in a federally approved car restraint. Generally, they're moving from a forward-facing car seat with a 5-point harness toward a booster seat.
And the rule for the booster seat is?
Nurses have to reinforce the safety guidance that a booster seat is required until the child reaches one of 2 criteria: 4 feet 9 inches in height, that's 145 centimeters, or R, they're 8 to 12 years old. This is the gold standard. It's non-negotiable.
Why is that specific height, 4'9", the key?
It ensures that the adult lap belt lies low across the hips and upper thighs, and the shoulder belt crosses the middle of the chest and collarbone.
And if the child is too short?
The lap belt rides up over the abdomen, risking serious internal injuries, it's called seatbelt syndrome, in a crash. And the shoulder belt rests dangerously across their neck or face. We teach parents to ignore the pressure to transition them out early.
What about outdoor and pedestrian safety, given their increased gross motor freedom?
Since they're on tricycles and moving toward bicycles, protective equipment is non-negotiable: helmets, knee pads, elbow pads. For pedestrian safety, we need structured, repetitive teaching of the stop-look method.
Stop at the curb.
Look left, look right, and then look left again before crossing. Because they are still so egocentric, they need to practice recognizing that cars are fast and cannot stop instantly for them.
Okay, moving inside the home. The major preventable risks are drowning, poisoning, and burns. Let's start with drowning, which sees a spike in this age group as they become fearless near water.
Drowning risk is paramount. Preschoolers must never be left unsupervised in bathtubs, near wading pools, or any body of water, not even a small bucket of water.
And what about swimming lessons?
While swimming lessons are recommended for children 4 years and older as a skill-building exercise, nurses have to teach parents that lessons are not a substitute for active, constant adult supervision.
That is a classic test question because lessons can give parents a false sense of security. So what does active supervision really mean for this age?
It means the adult should be within arm's length, or touch supervision, not just sitting nearby reading a book. The child should always be the focus of the adult's attention. Even a brief distraction, answering a phone, walking inside for a moment, can be fatal for a preschooler.
Okay, now for poisoning, which ties directly back to their cognitive process of transduction.
Right. Because of transduction and their preoperational thought, they mistake look-alike substances. They might see a colorful cleaning product that resembles juice, or a vitamin that looks like candy. They just lack the logic to understand chemical danger.
So the teaching point is,
Nurses have to teach that all cleaning, garden, and automotive chemicals, and all medicines, including vitamins, Tylenol, iron tablets, must be kept in locked cabinets, up high and out of sight. Childproof caps offer a barrier, but not total security against a curious, persistent 5-year-old.
and what about burns? What is the single most effective intervention against scald burns?
The key intervention is managing the water temperature. You have to ensure the household water heater thermostat is set at or below 49 degrees Celsius, which is 120 degrees Fahrenheit.
Why that number specifically?
Water at 140 degrees F can cause a full-thickness burn in less than 5 seconds. At 120 degrees F, it takes minutes, which allows the child time to react and pull away. That number, 120 degrees F, is high-yield safety data.
And finally, firearms and falls, especially in the hospital environment.
Firearms pose a risk because a preschooler has the physical strength and coordination to handle and fire a weapon. They should be stored unloaded in a locked cabinet with ammunition stored separately and locked away.
And falls.
Their improved mobility encourages risk-taking behaviors like climbing on railings or jumping off furniture. In the hospital, this means increased vigilance, clear rules, and ensuring side rails are up, as their initiative can quickly override their sense of caution.
Okay, time for the summary. What do nurses watch for?
You're watching for parents planning to graduate a child out of a booster seat prematurely. You have to reinforce that critical 4'9" height requirement. And you're monitoring the home environment for accessible poisons or high water temperatures.
And what exam writers love to test?
The specific maximum water temperature, 120 degrees Fahrenheit, to prevent scald burns, and the mandatory teaching point that swimming lessons do not replace constant active adult supervision.
And the easy way to remember this age group.
They are highly mobile, highly curious, but crucially, they lack the cognitive judgment, that preoperational thinking to assess danger, which leads to high-risk exploration.
This section is pure, clinical, high-yield material. The 4 to 6 year visit is the final push before kindergarten, and it's characterized by a cluster of mandatory booster shots.
We lovingly call this the 4-shot 4s.
I like that.
This is the checkup that ensures completion of the primary series for 4 major diseases. The 4 key doses administered between age 4 and 6 are DTaP, which is diphtheria, tetanus, and acellular pertussis.
IPV, inactivated poliovirus.
MMR for measles, mumps, and rubella, and VAR for varicella. Mastering the nuances of DTaP and IPV is absolutely essential.
Okay, let's start with DTaP. It's a 5-dose series. What are the rules surrounding that 4 to 6 year dose?
The dose given at 4 to 6 years is typically the 5th and final dose of the childhood series. However, here is the rule that exam writers love to use as a catch-up scenario. Dose 5 is unnecessary if dose 4 was administered at age 4 years or older, and the other was at least a 6-month interval after dose 3.
Okay, so picture this. A child is 4 years and 3 months old. They got their 3rd dose at 18 months and their 4th dose at 48 months, which is age 4. Since dose 4 was given after age 4 and it's been way more than 6 months since dose 3, they're good. They don't need dose 5.
Precisely. If, however, they received dose 4 at 3 years old, they absolutely still need dose 5 at their 4 to 6 year visit, as long as it's been 6 months since dose 4.
The rule protects against unnecessary dosing while still ensuring immunity.
Right.
Okay, IPV, inactivated poliovirus, is the other vaccine with complex final dose timing.
IPV is a 4-dose series. The dose administered at 4 to 6 years is the 4th and final dose. The absolute requirement is that the final dose must be administered on or after age 4 years A&D at least 6 months after the previous or 3rd dose.
So if a child gets that 4th dose at 3 years and 11 months, that dose is invalid.
It is. It's considered invalid because it was given before the minimum age of 4 years.
Okay, MMR and VAR are simpler. They're both just getting their 2nd dose.
Correct. Both MMR and varicella start their series around 12 to 15 months. The 4 to 6 year visit is for that 2nd or booster dose. These are crucial for long-term immunity against these highly contagious diseases, especially as the child enters the dense environment of elementary school.
Let's talk about combination vaccines. They reduce the number of painful injections, which is a major win for a preschooler with a fear of bodily harm.
Combination vaccines are efficient, but you have to know the specific ACIP contraindications.
Yeah.
For instance, MMRV combines measles, mumps, rubella, and varicella.
And there's a critical test alert here.
Yes. MMRV is not recommended for ages 12 to 47 months due to a slightly increased risk of fever and febrile seizures compared to giving MMR and VAR separately. And it's also not recommended for ages 13 to 18 years.
So if you have a child in either of those age windows, you have to give the two vaccines separately.
You must. That is a classic trap question. Know those two age groups where MMRV is contraindicated.
Okay, let's talk about the annual influenza vaccine, which is required starting at 6 months.
Annual flu vaccination is mandatory for everyone 6 months and older. The dosing rule hinges on prior vaccination history for children under 9.
How so?
Children aged 6 months to 8 years require 2 doses, separated by at least 4 weeks, only if they have received fewer than 2 doses of any flu vaccine before July 1st of the current season.
And if they're 9 or older, or they've had those 2 doses before,
Then they only require 1 annual dose.
and the absolute mandatory testable contraindication regarding the live attenuated influenza vaccine, LAIV3 or Flumist.
Since LAIV3 is a live vaccine given intranasally, it has several important contraindications. The high-yield one for this age group. It is contraindicated for children aged 2 to 4 years with a history of asthma or recurrent wheezing.
Why is that?
The concern is that the live virus could potentially exacerbate their reactive airway disease. So if a parent requests Flumist for their wheezy 4-year-old, you have to refuse and administer the inactivated injectable vaccine, the IIV. Other contraindications include being immunocompromised or having close contact with severely immunosuppressed individuals.
Before we leave immunizations, let's quickly review the critical rules about administration timing. The 4-day grace period versus the repeat dose rule.
These rules ensure valid immunity documentation. Doses administered up to 4 days before the minimum age or minimum interval are considered valid. It's a minor grace period. But doses administered 5 days or more earlier than the minimum age or interval should be considered invalid, not counted, and must be repeated. So if the minimum age is 48 months and they got the shot at 47 months and 25 days, it's invalid. It has to be repeated.
And what about the major contraindications for live vaccines in general?
Live vaccines, so MMR, VAR, LAIV, rotavirus, are generally contraindicated in the presence of severe immunodeficiency. This includes chemotherapy, congenital immunodeficiency, or high-dose, long-term immunosuppressive therapy. They are also contraindicated during pregnancy. The nurse must always screen for these conditions before administration.
Let's do the wrap-up. What should nurses be watching for?
Ensuring the 4 to 6 year boosters, DTaP, IPV, MMR, and VAR are correctly documented and timed, and rigorously screening patients aged 2 to 4 for a history of wheezing before you even think about administering LAIV3.
And what do exam writers love to test?
The complex catch-up rule for DTaP, so dose 5, and the IPV final dose timing. Also, that LAIV3 contraindication regarding asthma or a wheezing history.
And one easy way to remember this age group.
The 4-shot 4s, DTaP, IPV, MMR, VAR, they mark school readiness.
Now that we've covered their structure, their mind, and their mandatory shots, let's look at the daily clinical concerns nurses address. Sleep, nutrition, and common behavioral issues. Let's start with sleep, where nighttime arousal issues frequently come up.
They do. Preschoolers generally need about 10 to 13 hours of sleep daily, and most begin dropping their afternoon nap around age 4 or 5. The critical skill for the nurse here is distinguishing between the two major causes of sleep disruption: nightmares and night terrors. They're managed completely differently.
Okay, lay out the fundamental difference for us, because this is confusing for parents and it is highly testable.
A nightmare is a bad dream. It occurs during REM sleep, usually in the second half of the night. The child will fully awaken, cry, be scared, and crucially, they will remember the dream. They respond to their parents' comfort and reassurance, though they often return to sleep with difficulty because they're conscious and scared. They're aware of their parents' presence.
So it's a true scary dream. What about a night terror?
A night terror is a sudden partial arousal from deep non-REM sleep, and it usually happens about an hour after the child falls asleep. The child may thrash, scream, sit up, stare, appear terrified, have a racing heart, but they are in an altered state of consciousness.
So they're not really awake.
They're not. They are generally unaware of the parent's presence, they do not remember the episode the next morning, and they often fall back asleep rapidly without fully awakening.
That distinction, the memory, the awareness, and the time of night, that is everything. So the intervention for a night terror is essentially minimal interference, right?
Exactly. For a night terror, the parent should gently ensure the child is safe from injury, but avoid trying to fully awaken or comfort them, as the child isn't truly conscious and may resist. The intervention focuses on prevention, establishing a consistent bedtime routine, making sure the child isn't overtired, and avoiding stimulating activities or media before sleep.
Okay, let's pivot to nutrition. Growth has slowed dramatically from toddlerhood, which means their appetite often becomes erratic, and that causes parental anxiety.
Their appetite decreases because their growth rate has decreased. Their caloric needs range from about 1,000 to 1,600 kilocalories a day based on their size and activity. We need to focus on the key nutritional requirements: 700 to 1,000 milligrams of calcium for bone growth, 7 to 10 milligrams of iron to prevent anemia, and 8 to 10 grams of dietary fiber for GI health.
And what is the high-yield nursing guidance for managing that picky eater phase?
We guide parents to offer small, appropriately sized portions, encourage the child to self-feed, and crucially, allow the child to decide when they're full. Never force food or turn mealtime into a battle.
Because that can lead to negative associations or eating disorders later on.
It can. We also emphasize family mealtimes as a chance for parental modeling of healthy choices.
And what about the two major numerical health promotion facts that appear everywhere? Juice intake and screen time limits.
Absolute must-know facts. For nutritional health and the prevention of dental cavities, fruit juice intake must be limited to a maximum of 4 to 6 ounces per day. Any more than that displaces nutrient-rich foods and contributes excess sugar.
And for screen time, given their engagement with electronic games and TV.
To promote social interaction, physical activity, and adequate sleep, screen time, which includes television, tablets, phones, must be limited to a maximum of 1 hour per day for this age group. Nurses have to be firm on this guidance, especially when counseling parents about childhood overweight and obesity.
Which leads right to our final high-yield clinical concern, the management of weight status.
Overweight is defined as a BMI at or above the 85th percentile, and obesity is at or above the 95th. These children are at risk for developing adult health complications like hypertension, hyperlipidemia, and type 2 diabetes.
So nursing interventions are key.
Yes. We encourage 60 minutes of daily physical activity, and we enforce that screen time limit of 1 hour per day. Our role is focused on prevention and early intervention to manage these risks.
Let's do the final summary for this section. What do nurses watch for?
You're watching for parents' confusing night terrors, which are partial arousal with no memory, with nightmares, which are full awakening with memory. We have to ensure parents know how to differentiate and manage each event correctly.
And what exam writers love to test?
The direct numerical health promotion limits. Maximum juice intake is 4 to 6 ounces per day, and maximum screen time is 1 hour per day.
And one easy way to remember this age group.
They are the sleep-scared group, frequently dealing with nighttime arousal issues that demand clear differentiation and consistency in their bedtime routine.
Wow. We have navigated the incredibly complex world of the preschooler, ages 3 to 6. This deep dive has really highlighted why this age is so critical. They're the bridge from dependent toddlers to independent school-age children, a period defined by the explosive growth of their conscience and their imagination.
The essential concepts to lock down for your exams and clinicals remain the 4 key vaccines due at that 4 to 6 year checkup: DTaP dose 5, IPV dose 4, and the second doses of MMR and VAR. And remember Erickson's stage, initiative versus guilt, which centers on the development of conscience through action and consequence.
And you can never forget Piaget's cognitive limitations: magical thinking, transduction, and animism. These illogical processes dictate their fear of bodily harm or mutilation in the hospital and explain why safety education, from the 4'9" booster seat rule to the 120-degree water temperature, has to be so specific and so consistent.
The preschooler has a truly imaginative mind, but this imagination struggles profoundly with abstract concepts, and most notably, the concept of time. They live in an event-based world, not a time-based one.
So let's revisit that challenge for you, the future nurse. Knowing that a 4-year-old struggles to grasp the concept of time, how would you explain a complex treatment plan like the need for antibiotics for 10 full days in a way that genuinely respects their pre-operational mind and promotes compliance? You can't use Thursday or in 10 days.
You have to anchor the time to a concrete, predictable daily event. So instead of saying, you will take this pink medicine for 10 days, you would say something like, You will take this pink medicine every morning right before you eat your favorite cereal, and every night after we read the bedtime story. When the medicine bottle is completely empty, that means you are all better.
That's the core application. We swap the abstract calendar for the concrete, predictable daily ritual. And that's how you move from just knowing the facts to truly understanding and applying pediatric care.
That level of application is what ensures success, both on the high-stakes test and at the patient's bedside.
That's it for this deep dive. Go integrate that knowledge, and we'll catch you next time for another essential breakdown of clinical information.